problem with prostate cancer is that it has an extremely high prevalence. That is to say, it's estimated that almost 50% of men over 50 years of age have prostate cancer. The problem is that, or rather the advantage is that it's microscopic and only a percentage of them, which can reach up to 40%, may need treatment. If we look at those the age of 80, almost 80% of people may have carcinoma. The problem is detecting carcinomas that are clinically significant. That could have an impact on the patient's health. So MRI is a very useful tool precisely for that purpose, to detect injuries that are going to occur. I believe that right now a diagnosis is one of the key pieces, but the evaluation is complex. It requires experience. That's why probably help from artificial intelligence tools will be very useful. Specifically, it uses biomics. That is, it tries to detect lesions that are not perceptible to the human eye, but can be detected by artificial intelligence, such as texture-related issues, etc. I think that right now, having these artificial intelligence tools, in this case from QBeam, I believe it can be very useful. A tool such as QP Prostate, in artificial intelligence developed by QBeam, I think helps a lot because it integrates so easily with the system. This means we'll directly have the images in the packs already processed, where targets will appear, showing a probability of clinically significant carcinoma. But also another very important thing about the QBeam system is that it's going to perform a very, very precise segmentation of the prostate. So we'll automatically have the dimensions and volume of the prostate, which really speeds things up. Because when calculating PSA density, you already have the value and very precisely. Well, clearly, in the area of lesion detection, having tools like artificial intelligence, for example, the QBeam tool is very useful because it will help us identify those lesions that are going to be more clinically significant, that may have more greater aggressiveness. Clearly, we have a problem now with so many MRIs. In one work shift, there can easily be 10, 15, 20 MRI scans. If we assess this in a year, there can be 1,000 scans at the center specializing in prostate. Of course, trying to be consistent with the diagnosis of these lesions and having a tool to help standardize the diagnosis will be of great help. Automatically, when we open the packs and see, we'll have the study with all the sequences, and we'll also have a QBeam study which will tell us, besides the segmentation with the volume, it will indicate lesions with a probability of corresponding to a clinically significant cancer. And it's going to do it in a very simple way. It will have a parameter, an orange color, for example, for more aggressive lesions, which would be equivalent to grade 4, grade 5, and some lesions we should pay attention to, but could be equivalent to a grade 3. In any case, it's very important to evaluate these lesions because they might have gone unnoticed in a normal reading.